I'll pay attention.
Okay, it's 12:01, so I'm gonna let people in. I'm recording because I guess
John, please start the music.
John is not here.
He got kicked out.
He got kicked out, yeah, so I guess it's luckily that I'm here early. I can record, I do not have the music. Let's see, John.
I have given the file to everyone.
Yeah, but I don't have it downloaded, so. Okay, I think I have to share screen in order to be able to do this.
Okay, no worries, Michaela. We just let people in. Forget about all this.
Okay, I'll let them in then.
We'll go with the flow. Good afternoon. Good afternoon and welcome everyone. So we get started. My name is Sarah Tomkison and I'm a social worker with the Geriatric Echo team. Welcome again. The CME activity is jointly provided by the Queens Medical Center and the University of Hawaii Jabsum Department of Geriatric Medicine. We thank you for joining us, and at this time, I'm asking that you please enter your name and your credentials for viewing Geriatric Echo. And this is also for the purpose of CME attendance. As a kind reminder, evaluations are required for the CMEs, and you can find the evaluations by email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. We want to remind everyone that this is an ECHO webinar, which means that the session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. So it will take all of us to create this community of learning. Just a little bit about our format. After a short lecture from our presenter, we will share expertise from the rest of the team and then open time for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to today's topic lecture. We only ask that you keep it HIPAA compliant for discussion, and that means please do not share the patient's name, birth date, address, and so on. We learn best from our patients and clients, and they are our best teachers. I'm joined today by our interdisciplinary team, and we are all willing to teach and share our collective wisdom and experiences with you. So please welcome our advanced practice nurse. Courtney may not be here, but if you are Courtney, welcome. Courtney Nunu Hawa is an advanced practice nurse in geriatrics. We have our pharmacist, Tad Kawakami, joined by psychologist Lucas Morgan, our geriatrician Rita Bell, and of course myself, Sarah. It now gives me great pleasure to introduce today's speaker. Dr. Susan Christensen also has a master's in business administration, and she has been a family physician with over 15 years of primary experience in Hawaii. After observing the struggles of her older patients and their families in navigating an increasingly complex healthcare system, Susan stepped back from primary care to pursue fellowship training in geriatrics so that she could be a better resource for all of her patients and families' needs. In her free time, she enjoys distance running, watching her daughter play volleyball, and playing with her 3 dogs, who will make a brief appearance in today's presentation. Thank you and welcome, Susan.
I forgot to put the picture of the puppies in. That's okay. Good afternoon, everyone. Thank you for joining us today for a brief foray into some essentials of law and ethics in elder care.
Sorry, Susan, it looks like you got muted. Can you unmute again?
Okay. Did you hear me at all?
I just
No.
want to say, this is Dr. Saltman. I'm sorry, the chat is also disabled, so there's no opportunity to use the chat.
Okay. All right. So, oops, quickly going back. So thank you for joining us for a brief foray into some essentials of law and ethics in elder care. We have, forward. There we go. We have important and challenging topics to touch on this afternoon. As people age, what can be done and what should be done for individuals becomes more of a gray area than it would be for a younger person. Not only are we looking at a person's multiple health issues, but we also have to consider whether they are able to understand their options, what their support network looks like, and whether there are ulterior motives at play. That is a heavy burden. I think of aging as going from a one-man canoe, light and manageable, to a 6-man outrigger. Can you imagine paddling a 400-pound canoe by yourself? In geriatrics, we rely on interdisciplinary teams to share the load. To keep the canoe moving in the direction we want to go, we fill up the seats with the support of other disciplines. In calmer waters, 2 or 3 team members can probably manage, such as a clinician and a pharmacist sorting out medications, or a social worker and a caregiver arranging for home care services. In rough waters, we need to fill every seat, our coaches advising us, and the entire club working in the background to make sure that we get where we are going. But before we dive in, I would like to pause and ask for you to think about yourself. What is your role? What is your kuleana? Who is your team? Where might you find the external help when you need it? Even more important, I wish to challenge you to reflect on your own values. What are you bringing to the table? How might you be influencing the situation? If you aren't able to recognize what is important to you, then how can you separate that from what is important to the patient? Life and business strategist Tony Robbins puts it this way: values are the fundamental beliefs that govern our lives. They are our inspiration to act, and they guide our decisions about everything. They embody who we are, the person we want to be, influencing how we treat others and how we interact with the world. Values are the core of who we are. Here are a few examples of core values. We have all seen them as a part of a business's mission and vision statement, but we can apply them to ourselves too. So after our talk today, take a few moments to identify 3 core values within yourself. I think of them as the beliefs that when challenged or compromised, kind of give you that yucky feeling. Along the way, we are also faced with ethical dilemmas, which can come about when there is uncertainty about what the right thing to do is, or where there are conflicts in values between stakeholders. A way to navigate those dilemmas is to identify the ethical principles at stake and prioritize them according to the patient's values and the law. Basic principles to consider are autonomy. This is where the patient gets to decide what is best for themselves. Beneficence, these are the positive actions that we take to have better outcomes for our patients. Confidentiality, we're protecting the patient's privacy. Non-maleficence, the actions that we take do not harm the patient, or we refrain from negative activities. And then there's equity and justice, making sure that we're providing care equally and fairly across the spectrum of our patients. Because our American culture values autonomy and self-determination above all else, healthcare decisions typically default to the patient's choice. Yet in elder care, we have an obligation to ask one more question. Does this patient have the capacity to make a decision? So what is decisional capacity? Quite simply put, there is no single conclusive answer to that question because there are different situations that require a different level of understanding. If you think of a child choosing between two vegetables, it doesn't matter which one they choose, the outcome is going to be good for them as long as they're eating a vegetable. But if you give them a choice between a cookie and a vegetable, it's less likely that they're going to be able to take in the information and then choose what is actually better for them because they're going to rely on what they want and not necessarily what's best for them. Terms like competency and capacity are often used interchangeably. Distinctions can be made between them, however. Competency is more often used in the legal and global context, whereas capacity is used more often in medicine and is applied situationally. There are 4 essential elements to capacity. Can the patient receive and understand the information? Does the child get that the cookie is a treat and the vegetable is necessary for their health? Can they weigh the risks and benefits? Are they able to express a clear and consistent choice over time, or are they changing back and forth depending on their mood or whether their mother is standing over them and looking sternly at them? Are they deciding voluntarily without undue influence or coercion? Capacity is situation specific. Many providers don't think about capacity much in their day-to-day work, but it is an integral part of something that we do rather routinely, which is to obtain consent. We have to provide adequate information to the patient, then they need the capacity to make a decision, and that capacity is often presumed. And lastly, the decision needs to be voluntary. In order to give adequate information, first we have to make sure we are communicating effectively, using understandable language and words. We are getting better at providing information in a patient's native language or obtaining an interpreter, but have you made sure that your patient can hear and see and read as you go through these other elements of consent? And here are those 4 elements of capacity again. And when a decision is finally made, it must come from the patient. This is where we as providers have to be extra careful to make sure that our interest is in the patient's desired outcome, not our own. Even if a patient makes a decision we don't agree with, we cannot abandon them and turn our backs. When might a letter of capacity be needed? The need may arise in situations where medical issues impact cognitive abilities, whether acute or insidious, such as dementia, stroke, mental illness, traumatic brain injury, or delirium. A letter may also be needed in order for a power of attorney to take over fiduciary responsibilities. And this is an example of legal script for incapacity. There are problems to be considered when writing a letter for permanent disability, for permanent loss of capacity. First and foremost, have you thoroughly explored the possibility that the loss of the capacity is reversible? And secondly, are there motives of the person requesting the letter for the benefit of the patient? That brings us to the matter of the vulnerable adult and our obligation to report situations of abuse or self-neglect. A vulnerable adult is anyone 18 years or older with a mental, developmental, or physical impairment who is also unable to communicate and make responsible decisions to manage his or her own care or resources, carry out or arrange for essential activities of daily living, or protect oneself from abuse. What is Adult Protective Services? They are the agency within the Department of Human Services which receives and investigates reports of abuse. They are able to provide short-term services to protect health, safety, and welfare of vulnerable adults. The immediate safety of the patient is their primary goal, with resources to stabilize the situation. DHS, or Department of Human Resources, can only act with the consent of the vulnerable adult, unless a court order for immediate protection is obtained. A court order requires a medical determination that these clients lack capacity to make decisions concerning themselves. In cases of self-neglect, there is an immediate risk of death or serious harm. This means that even though someone else thinks a vulnerable adult needs help, it is if the person is able to make decisions, then that person has the right to refuse help and may choose a lifestyle that others do not think is safe or appropriate. Hawaii's health providers are mandatory reporters to APS for vulnerable adults whom the abuse has occurred already, or the vulnerable adult is in danger of abuse if immediate action is not taken. The self-neglect standard is higher and requires that vulnerable adults appear to be exposed to a situation or condition that poses an immediate risk of death or serious physical harm. Unfortunately, the Department of Human Services has limited resources to help individuals and was not provided with additional staff or funds to implement expansion of the Adult Protective Services law. They are vying for the exact same resources as hospitals and case managers throughout the islands, which means that a referral to APS is not a way of connecting patients to needed resources. A social work referral would be more appropriate in these cases. So we have an elderly patient who is living at home alone. They are safe, and our social worker has helped arrange Meals on Wheels to avoid food insecurity. So we're done, right? Our patient's okay. Wrong. Now we need to talk about the future, because the future always comes. It is a difficult conversation to start, but when the information is needed, it can help to guide family members in making challenging decisions in the best interest of their loved one. In Hawaii, there is no next of kin statute for medical decision makers. And if there is not someone designated to be a decision maker, it can lead to family discord. Advanced directives can include individual instructions for healthcare, which may be oral or written, and these are generally replacing what previously was called living wills. They also can contain a durable power of attorney for healthcare, in writing, dated, signed, and witnessed by two qualified individuals or notarized. It can be revoked It can authorize an agent to make any healthcare decision unless otherwise specified, effective only during periods of incapacity. The durable power of attorney for financial legal matters is a separate document covered under the Uniform Power of Attorney Act. So the DPOA for healthcare and the DPOA for finances are two separate designations, and one does not automatically become the other if both are not specified. They are separate documentations. The advance directives may provide instructions not to prolong life when death is imminent in those last 6 months of life, but this does not constitute a do not resuscitate order. Again, in Hawaii, there is no next of kin statute. If there is not a named decision maker, either in the form of an agent named in an advance directive or a documented surrogate in the medical record, then the burden is on the provider or their designee to identify as many interested persons as is practicable. From that group, a single person is selected by consensus to act for the patient. If no one is identified or a consensus cannot be reached, then the decision maker will be appointed through the court system in the form of guardianship. This process is expensive and time-consuming and not in the best interest of the patient, because often that guardian does not know who the patient is. Now we have a POLST. So a POLST is provider orders for life-sustaining treatment. It is a portable out-of-hospital medical order. It is a right now document. So if a patient has an advance directive, that is a description of what they would like for the future. This is a document that gives medical personnel instructions, actual doctor's orders for acting should something happen with the patient. It allows individuals to choose medical treatments that they want to receive and identify those that they do not want to receive. So when do we need both? I borrowed this slide from our friends at Kokua Mau because it explains it very clearly. An advance directive is a legal document that outlines the patient's wishes for end-of-life care and identifies agents for designated power of attorney for healthcare. A POLST, or a provider orders for life-sustaining treatment, is a medical order specifying what the patient wants in an emergency. Since do everything is the default, it is particularly important to have a POLST if you want less aggressive interventions and you are in that end-of-life window. If you would like additional resources on POLST, advanced directives, or starting a conversation about end-of-life care with your patients, I encourage you to visit the Kokua Mau website. They are a local nonprofit whose mission is to improve the quality of care at the end of life, and they are a wonderful resource. So lastly, I would like to cover elders living alone and what we can do to help those who do not have family members to rely on. Looping back to our interdisciplinary approach, caring for elders takes a holistic view of the whole person. We are fortunate that discussion of the social determinants of health have been at the forefront of healthcare discussions, as a lack of a social support are often the contributing causes for illness and frailty in geriatric patients. How does our patient access food? Who do they call when they need to talk? What do they spend their days doing? How do they get to appointments? One concerning aspect of their independence is that many of them continue to drive, which puts not only their safety at risk, but those in the community as well. Physical aging alone causes significant changes that affect the ability to drive safely. One of the challenges is that this does not occur on a set timeline for all individuals. So we cannot say, well, you're over 80, therefore you can no longer drive. We actually have to look at each of these physical elements and see where our patient falls on the spectrum. There are things that you can do as part of your annual wellness visit to give you insight into the patient's driving safety. If your patient is fortunate enough to be a veteran, the VA has occupational therapists who can assess them and provide recommendations to either make modifications such as no driving at night, or that it's maybe time to stop driving. These are some of the warning signs that family members may report. But if patients are living alone, you have to ask directly about accidents or tickets or damage to their car. If your patient does have to give up driving, there are many alternative means of transportation to keep our patients from becoming isolated. And there are things you can have family members and community members do to make sure that they get where they need to go. And the Uber, Lyft, and rideshare apps have revolutionized the ability for our senior patients to get places if they are tech savvy. Okay, so one last topic here is the difference between adult orphans and the unbefriended. So an adult orphan is an older adult who retains decision-making capacity, but is at risk of becoming unbefriended due to a lack of completed legal documents and lack of designation of a legally authorized decision maker. So these are our older patients who are completely functional. They still live in their own home. They're doing their grocery shopping, their home repairs, but they're alone. Their spouse has died. Their children are somewhere else, not helping them or not in their lives. And they have no one that they can identify as someone to step up for them. Those adult orphans become unbefriended elders when they lose the capacity to make decisions and have not completed legal documents. That can lead to decisions, then that leads to the legal process for us having to figure out who can speak for them. So often our unbefriended elders end up as requiring somebody to step in, a guardian. So where do we go for help? If you are fortunate enough to be in a large healthcare system, you likely have access to social work referrals. If you're on your own in the community, there are resources available to you. Here is just one example of one of the programs that Catholic Charities Hawaii offers to help elders living alone. They have something called the Memory Mentor Program. As providers, we have an obligation to protect the rights of our patients while at the same time keeping them safe and healthy. There are legal boundaries that we have to work within as well. It is a complex process, but we are not alone. If you would like to start exploring additional resources in addition to Kukuamau and Catholic Charities Hawaii, the Division of Elderly Affairs also has a recently updated website with additional information. Thank you for your time, and I'm happy to answer any questions or discussions that come to mind.
Thank you, Dr. Christensen, for a very eloquent and succinct presentation on decision-making capacity and medical issues with the elderly. It is a tough topic, that we face in clinical practice, and you have given us tools that we can use with our seniors in our practice. Thank you so much for a very beautiful presentation.
You're welcome.
I would like to open the floor up to thank you for all the attendees. We have so many people from the clinics and federally qualified health centers, and we'd like to open it up for discussion. If you have any case, any patient you are struggling with on this decision-making capacity, let's bring forth those cases and ask Dr. Christensen for her guidance.
Susan, this is Sarah. I just have a comment, which is also probably part of a question. From your own professional experience in geriatrics, can you share with us, have you come across any specific situations that were challenging with regards to being asked to do a capacity assessment?
Absolutely. So
What steps did you go through?
yes. So it's one of the reasons I decided to come into geriatrics is more and more often I was being asked to see geriatric patients in the community that I was not familiar with, because we were one of the few practices that were open to new patients, because so many doctors, their practices are full. And so it was not infrequent that a new patient would come with their son or their daughter, and they would request a letter of capacity so that the son or daughter could have access to the parents' bank accounts. And so it's very difficult when you don't know the patient, you don't know the circumstances, and you are relying purely on the information that the child is presenting as to whether the parent needs the help of their child to access the bank accounts. So the first step that I would do was a mental status assessment. So doing a mini COG or an MMSE actually, just to see if I could elicit any evidence of cognitive impairment. And then going through all of their activities of daily living, their IADLs, have there been incidents where bills were not being paid? But again, you're relying on someone telling you the truth. And so it's tricky, because at least previously, those letters of capacity were almost permanent things. So you write a letter like that, and then the patient might regain their capacity because whatever problem led to it has cleared up. And on the first time seeing them and trying to go through all of that, it's really, really difficult. So I would probably change my approach now and do a complete geriatric assessment and tell them that I can't write the letter immediately, that they can't have it today, that I have to complete a full evaluation, and ideally make sure that I'm protecting the patient's best interest, because the patient is who I'm representing, not the child.
You make an excellent point, so that we need to assess what the motives are for the person that's requesting, especially financial powers of attorney. And the fact that it could be a temporary condition if the person had a delirium, something like metabolic encephalopathy, right? Or I guess. But what
Right.
about other people?
What do you mean about other people? Oh, other
I
people.
mean, other people in the group
Oh,
as
yeah.
they face situations about,
Yes.
because it's not just about financial. I've had situations where it might be a capacity assessment for driving, and I'm not even sure That's been an issue for people.
Yes. So one of the interesting things about driving in Hawaii is we don't have mandatory reporting for safety. There is no one we are obligated to call if we know someone is getting behind the wheel of the car and maybe does not have all of the skills necessary, unless obviously if they're intoxicated, then we can call, because that's breaking the law. But we can't say I have an 89-year-old driver who can't turn his head more than 15 degrees to check behind them, and report them. That actually can violate privacy laws, HIPAA laws, if you do that. We have to be very careful. And in those circumstances, I more try to work with the patient directly and gain their buy-in to why they should stop driving. But it can be difficult.
Yeah.
Hi, so this is Lucas. I have a comment in the chat box, and wanted to read that. Relates to safety and consent as well, from Renata. How can providers encourage socialization within the elderly community after a spouse or significant other dies, but maintain safety and consent between the elderly so that both individuals who are more vulnerable are able to socialize without causing harm or unwanted advances? I don't know if Renata, you want to add any specifics to that, or if Susan, you have anything to go off of for that comment.
Hello. I don't know. I just have had several people, not necessarily patients, but just people I talk to that are elderly in the community who have this discussion with me, and I try to stay out of this portion of it because of, when it's in the community, it's sort of a different situation. But for people who are in assisted living or living in an elderly community who are in skilled nursing or whatever, I've had some people just randomly tell me that they met somebody within a facility, and I often wonder how that happens, and like how, there is there is that sort of like boundary, and I'm wondering how it how to guide them to, if they live in an assisted living facility, or skilled nursing or whatever, like how is that addressed so that everybody feels comfortable with what, I don't know. I don't know how I've never seen it happen, but I'm just asking how to address it if it does happen.
Are you referring specifically to intimate relationships, or are you more concerned about financial vulnerability with these relationships?
All of the above. I don't know how. I mean, I imagine if somebody is becoming more friendly and not it like over it becomes more than just a friend relationship. How does that, how do you monitor that, I guess, so that somebody isn't being financially or physically advanced without like them being able to have the capacity to do that. So I mean, I guess like even in the disabled community, there's always that concern too, where if somebody's in a wheelchair or has other issues, like how do you protect them from like unwanted advances, or even if they are wanted, so that it's,
Right.
I don't know, so that it's a respectful, I don't know, maybe I am overthinking this, but I know I've had several comments of this, that they've met somebody, and I just always wonder how do you protect somebody? I mean, it might be as similar to if you are a parent that has a teenager who's, but it's a little bit different when there's a teenager who's like growing to learn how to do this versus somebody who's like an adult who can can basically make their own decisions for the most part.
Right, right. So I think, oh, go ahead.
I was just going to take a shot at that.
Please.
So, Renata, so my parents are living in one of those assisted living facilities. They've been there for 5 years. And, we visit, all the kids visit. And from our observation, it's very kind of interesting because it's a congregate living situation. And in the last 5 years, it's like a big dormitory. So you have people kind of, no matter how old you are, people never change their values once they've kind of decided what those values are. So you have people in assisted living, and as long as I think they are cognitively intact, they have this right to autonomy and self-determination. But my mother loves to gossip, so she likes to give report on who's trying to hook up with who, and I finally, we sat down and talked about it a little bit, and I said, Mom, what look, you've got your husband. For a lot of these people, they're lonely, and again, we have values and certain judgments and prejudices that really don't change whether you're 24, 44, or 84. And so when we sat down and started talking about it, she finally realized, I guess that could be me one day, where I don't have the companionship, and I do feel lonely. And when you talk about the safeguards, I know at least for a lot of the other assisted living, I've worked at assisted living too, and I've worked in care home, there's safeguards with staff, CNAs, family. So, but yeah, it's hard when you're getting older and you experience so many losses in your life. I don't think there's anything wrong with people developing other friendships, and I've seen people holding hands, and it's not like they're looking for a romantic intimate relationship. They're really just looking for friendship. I don't know, Lucas.
Yeah, I mean, I agree. Of course, we're all trying to encourage social engagement for older adults, especially where loneliness is like one of the silent epidemics going on all the time, especially during the pandemic era, definitely. But so yeah, and I'd be curious to follow up with the question about those safeguards for folks who. So I do work with folks in adult independent assisted and nursing units, but I am not aware of any sort of do folks, do staff there, are there any designations to routinely assess for competency, or are there any standards to try to gauge who is maintaining competence in certain areas to monitor that ability or not? And I would guess it probably is not something that standardizes, kind of like a case-by-case basis when problems arise. But does anyone know of anything like that?
I do. So at all the assisted living facilities, whether it's Arcadia, Kahaluni, they have annual assessments. They do annual physical exams, and they involve the director of nursing. They ask for an actual report from your primary care provider. And most facilities have actually separate memory care units, or what they may call dementia sections. So there is staff there that all staff are continually trained to be made more aware, but there is a requirement, I know, at the plaza for these physical exams and at Arcadia and 15C.
Which is good. And so that could be a place where like competency issues get flagged, but I'm sure it's not uncommon that, lack of competence issues go undetected in some cases, because maybe there's not a thorough examination being done. So, I mean, I think regards to Renata's question, if I was a provider, I would just be really interested in discussing any new relationships that develop and try to ask the person, are there any red flags about, do you, trusting this person, and what are you choosing to share with this person right now? And what would you choose to not share yet? Maybe not your password to your bank account right now, but, sort of taking things slowly, but also encouraging, go for it if you really feel like you have a connection with this person. So.
The last thing I wanted to add, that I think the people that are most at risk for being exploited financially or even physically abused are in these kind of care facilities. It may come more so from the staff and not from client to client. And that's why we have a nursing home ombudsman program.
Dr. Christensen, I would like to share about a potential case where it was a struggle between autonomy and paternalism. It was this total tug of war. And this is a case that we had in hospice. There's a 66-year-old Caucasian lady who was discharged from Queens, from Dr. Fishberg's team, to hospice. She had stage 4 rectal cancer and was admitted to Queens because of colovaginal fistula complications, and she needed antibiotics, and so she was discharged to home. The past medical history of this patient is she has been a meth abuser. So we have methamphetamine abuse, depression, anxiety, and she was diagnosed with cancer in 2020. And it was complicated with large bowel obstruction. She had a colostomy place. She had a fistula, colovaginal fistula. There's wound problems. There's repeated UTIs, pelvic pain. So we get this patient in hospice, and finally, when we had her, she was living with her daughter. The social history is very complicated because this patient has been homeless a lot of their life, and then living with a friend and living here and living there. So finally, now she's in hospice, and the daughter decides she's gonna help her, and Mom, you can live with me. But the challenge our team had was, and I printed this out because I said, I'm going to read you the email I get from the nurse.
Okay.
The email says, Dr. Fernandez, can you please advise? Because taking care of her is really a challenge. So the hospice nurse is saying, I attempted to train her, our patient in wound care, as well as people close to her, the daughter and the roommate. But she refuses to look at it, refuses to let the people do it for her. We suggested long-term care placement and routine care, which she is also hesitant and agrees and disagrees. We tried to get an agency nurse to provide wound care, but she canceled the face-to-face. We are currently rescheduling appointments, and there is no date set as yet. So the team is totally frustrated, and they don't know how to provide care to this patient. And we're discussing this at our interdisciplinary team, and the supervisor says, you know what, we could discharge this patient for cause. She's not following the care plan. I said, that's an easy way out. Why are we going to discharge this patient? We need to work with them. And I also said, let's call APS. And I said, maybe we need to do, weekend visits, so we catch the daughter or catch whoever's at home on the weekend and send a team on the weekends. So we contact APS, and I'm going because of your slides. Your slides, you said, does the patient, can she understand? So she could understand.
Yes.
Does she understand the risk and benefits? She knew she was, dying, and she needed care for her wound, and she needed antibiotics for UTI. Could she communicate the decision? She could communicate the decision. But where we struggled is the decision kept changing. It was never stable over time. The fourth point on your slide, it
Right.
kept changing. So we say, let's call APS. Now I need to share with you, I've got that email also printed out. I want to share with you what APS said. So APS says that for self-neglect care, the patient needs to have all three criteria. And the three criteria that APS says for self-neglect is a vulnerable adult. That means she has to be physically and mentally incapacitated to care for herself. She needs to have incapacity. She must be deemed incapacitated to make their own decision. And she must be in jeopardy of death or serious physical harm. And when our social worker called APS, over that phone call, it was decided that, the patient, she has the right to refuse care. She has the right to be stubborn. She has the right to do whatever she wants, and she can still make her decisions. So the bottom line is APS didn't open that case. Now, what would you have said to our team?
I would have asked, has anyone asked the patient what is most important to her? What does she want from her health care?
Yes.
Yeah.
That was asked. And to her, she understood she was dying and she had a very strong belief in God. So she was very happy to have our chaplains help and, to be heard. I think maybe for her, she was, her pain was never acknowledged or she was never heard. So she valued having social worker and chaplain. And it was important to her that she was not homeless,
Okay.
So that was also, she was happy to be with her daughter. That was an important thing, that she was not dying on the streets. But this, facility versus being in the home, it was just a struggle, get another agency involved. How does one help a patient like this?
So by refusing care, is she hoping that her death will be accelerated? So is it?
No, on some days she'll refuse care, and on some days she's very fine with the team. So we had this Dr. Jekyll and Mr. Hyde kind of situation. We had good days and we had bad days. So it depends whether she was high. I presume that she was still using meth. That was my, presumption. So we had days where she could, be very sane and logical and sweet and kind and the nicest person.
Okay. I guess then trying to break down what's different about those days. And, if those are the days she's high, then, obviously we can't condone her using illegal drugs, but if those are the days that we can provide her care, is that, a means to facilitate getting her good care? No, that's definitely challenging.
We have a comment from Dr.
I don't know if you've seen the
Saltman.
comment in the chat box, Dr. Fernandez. Couple of comments in the chat box. One is from Dr. Saltman. It says that it's not that uncommon for people in extreme or dire circumstances to have a lot of ambivalence about what they want or what to do or want to do. Would there be some way to more effectively engage her for the longer term, if not actually long term?
Yeah, we were trying to engage her for the longer term by trying to move our visits from weekdays to weekends. So we were going to get the weekend, the after hours team involved, because we wanted the visit to be there when the daughter was home and the daughter was working during weekdays. So that was one of the change we were going to institute, that we will engage by trying to do weekend visits. And then Renata's question is, was the patient always ambivalent about life decisions? We only got this patient in July of 2022. We're a hospice provider, so we only got this patient at the very end. I will tell everybody how the story ended. After we have all these things rolling in place, call APS, we're going to do weekend, we're going to do it like this, we're not. Then the patient passed away. So So she is no longer with us, but it was a struggle. It was a struggle for our hospice team.
Mhm. Yeah.
I just wanted to add to, and just as a psychologist, a lot of my work is being with folks' ambivalence. And so ambivalence is actually, in my experience, one of the most natural states for human beings to be in, especially around big things or challenging things. Feeling more than one way about something is like, it from the outside, it might be, so we might have a lot of assumptions about what someone should want in many cases, but oftentimes the real motivations or the underlying forces of those ambivalences are invisible to us. And so um, it's tough without having an opportunity to have a relationship where there can be trust and atmosphere where that ambivalence can be explored with the person, if they're even aware of what the ambivalence is about. So just to want to encourage folks to just, that ambivalence is one of the most natural and expected things, and that yeah, just to validate the importance of exploring that, I think, as Dr. Saltzman was talking about too. Anyway, very cool case, Dr. Fernandez. Very challenging.
Thank you for bringing that ambivalence as a normal state. We should expect it more rather than being surprised. Thank you, Lucas. And I appreciate everybody's feedback. Yes, Sarah.
Yeah, I was just going to add, I think your team did a wonderful job because she was still able to gravitate to the chaplain and to the social worker. So definitely she was processing whatever happened in those conversations. Like, Lucas said, she probably was working through some of those.
Thank you. Thanks for bringing that
Yeah.
up. Renata has a question. Your hand is raised.
Hi, I just have a quick question. If a family member has a family member who's who's about to die, or like 6 months to a year life expectancy, and all throughout their life they didn't want a certain family member involved in the care, but then towards the end of life, then they all of a sudden change their mind. How, the family member that wasn't welcomed in the care of the terminally ill family member, how should that person feel? Like, I don't understand how that person would feel comfortable then all of a sudden becoming part of the care at the last stages of life. Maybe just to be there, but if someone is sort of like teetering on the mental capacity, or if they have dementia or other mental issues, I can imagine that there would be some disconnect or concerns from the family member who is now welcomed and wanted in the care at the last stages of life, but has never been accepted before. Like, how do you address that?
And Renata, what you say, you see it happen more times than not. And what you see is the power of reconciliation and forgiveness. You never say never. And that's all I can say. You had patients who have said one thing and then they change their mind. And sometimes it is working through this existential suffering that often there is a lot of forgiveness and peace. So family members who on the out is now on the in. And I've seen it happen quite a few times.
Yeah, and they may end up, the person who's being invited back in may reject that invitation. I've seen that as well. So I think you invite them and let them know what they are being invited back to, and then let them make the decision as to whether they want to be a part of it, if it was a challenging relationship in the past. So yeah, I think it's all just support and conversation.
I know we are at the 1 o'clock hour, and I want to thank everyone for your participation, for joining us in creating this community. It's a community of learning. It's a community to help our seniors. It's a community to make our island a better place. And I thank you all for sharing your lunch break with us, and Dr. Christensen for a beautiful, eloquent presentation. Thank you so much to the Hub team, and please go and do the evaluation. We want everyone to get CME credits, so let's complete this. It won't be painful. Short and sweet eval. Mahalo. See you next month. Thank you.
Good job, Susan.